All right, let's get started. Hello, everyone, and welcome to the Global Surgery Friday academic meeting. Thank you so much for being here, and I'll introduce our wonderful guests in a moment. My name is Jo Park-Ross. I am a lecturer of simulation education, and some of you may know me from the PhD program or the Masters of Health elective. Very excited to have you all here and very excited to hear from our speakers. Today, we're going to be talking about universal health coverage, and what we're going to do is have Professor Susan Cleary from the School of Public Health start first, and then we're going to have a second speaker, Dr. Jennifer Hahn from the Harvard PGSSC Fellowship Program as our second speaker, and thereafter we'll take questions. As we go through, please keep popping your questions into the chat and I will monitor them. And I'm just going to ask you to keep your speakers muted, your microphones muted, not your speakers. We want you to be able to hear. Keep your microphones muted until we reach question time. So without much further ado, I'm going to introduce you to Professor Susan Cleary, who is a health economist by background, but our wonderful new head of the Public Health School. Sue, over to you.
Thanks, Jo. So hi, everybody, and thanks so much for having me here today. And so I'm going to be talking about universal health coverage, but specifically I'm going to be speaking about priority setting, which is an area that draws from many of our different disciplines, not just health economics, but is broader than health economics, but is something that I'm extremely passionate about. So in my talk, I'm going to start with an overview, and I'm going to center my talk on the South African situation. So I'm going to start with an overview of our current public health system and speak about some key concerns that I think we all are aware of in terms of efficiency, equity, and quality. I will also touch on our current economic context, which is extremely gloomy. Then I'll speak about this notion of universal health coverage. What does it mean? And how do I think that in the implementing of universal health coverage under the proposed national health insurance, how that might provide us with an opportunity for improving efficiency, equity, and quality, despite the fact that the financial situation is so extremely gloomy. And I will illustrate this through speaking about what I see as the role of priority setting in selecting the services for the UHC system. So that's briefly what I'm going to do in the next sort of 15 to 20 minutes. So the South African public healthcare system, which serves the majority of the population, has a number of challenges. So economists and health economists quite like to talk about the demand side and the supply side. So on the demand side, we know that there is a large burden of disease and that has been growing. And we know that there is inequitable access to quality care. On the supply side, we know that we have this tendency to be extremely aspirational in our policy making. And so almost always our policies are based in where we wish we were and aren't always grounded in reality. And some of these policies are also determined by political heads as opposed to by the officials or consultants or people such as myself. And my view is that if we're going to be aspirational, we're going to sacrifice equity because it's going to be impossible to achieve both equity and quality with the available resources. So this is a bleak picture about our economic context and what we've been through in the past number of years during COVID and some of the impacts of the global COVID lockdown. So even if we did whatever we did in South Africa, the economic contraction was a global phenomenon, and we therefore, in a way, had to accept the situation we found ourselves in. And these are three key metrics that economists like to use: gross domestic product, employment, and investment. And you can see that with the index being in December 2019, you can see that as soon as we pretty much hit the COVID situation, we had a massive shock, really a massive shock on three key indicators. particularly on investment. And as economists, that is one of the ones we'd be most concerned about, because investment pretty much determines your future growth. And with a contraction of investment, you worry. But then you also worry when you have a contraction in employment, particularly because it was not like we were doing that well on employment before either. And so to see this black line of employment and what has happened to unemployment, I think is a key consideration. I think that it is looking a bit better than this by now, but this was the most recent graph that I was able to find from our National Treasury. We also know that while one would want to be able to debt finance oneself out of a crisis to a certain extent, there are limitations in terms of what South Africa can do in this regard. And I think something that's very important for colleagues to know is that in the global north, largely they are able to borrow money at either a 0% interest rate and sometimes even a negative interest rate, meaning that it pays them to borrow money. And this is definitely not the case in a context like South Africa, where we always are facing a positive real interest rate. And so insofar as we borrow money, we have to be concerned about the debt servicing costs thereof. And there's a big difference between what we were able to debt finance during COVID versus what the global north was able to do. So of consolidated government expenditure of 2.16 trillion, we see at the moment that our debt service costs of 301.8 billion are higher than the amount that we're allocating towards the public healthcare sector. And because of this, for the first time in a long time, we are faced with a situation of a decline in the real per capita budgets in the public healthcare sector. And a number of us will be aware of this, and it's definitely a tricky time that we find ourselves in. So that is the gloomy economic context. But even so, it is still possible to make progress on universal health coverage. So the standard definition of UHC from the WHO is to provide all people with access to needed health services of sufficient quality to be effective, and to ensure that the use of these services does not expose the user to financial hardship. The goals are therefore utilization relative to need, which is basically an equity statement. There's no point in providing equity if quality is terrible. So there is the proviso that the service needs to be provided at an adequate level of quality in order to be effective. And then the third goal is to provide for financial protection, which is associated with protecting individuals and households from catastrophic healthcare expenditure. So this diagram is coming from Joe Cutzon at the WHO and is called Pathways to UHC Goals. And I really like it because it helps us to understand some of the key aspects and some of the key pathways towards UHC. So what you have on the left-hand side is your health financing arrangements to do with how you collect your revenue, how you pool your revenue, and how you purchase. And you probably all heard about the emphasis nowadays on strategic purchasing within the proposed National Health Insurance Reform. Then in the middle, you have these intermediate objectives. And the idea is that to the extent that you achieve these intermediate objectives, you're getting your system closer towards your UHC goals, which are pretty much what I said before. So that's utilization relative to need. So that's your equity goal of quality services, but also in a way that there is universal financial protection. And in the proposed National Health Insurance for South Africa, while already we have no user fees at the primary healthcare level, within the proposed NHI, there will be no user fees anywhere in the system, which is something that I support, meaning that we will already be coming quite close to this idea of universal financial protection. There are other costs to accessing care, but without user fees, it is said that we will be moving closer towards universal financial protection. But obviously then that aspect of revenue is off the table. And so given the gloomy economic context, the area that we are needing to consider is this area that is called benefits, sometimes called services, sometimes called interventions, sometimes called the healthcare benefit package. But it is this area of deciding what it is the UHC system is going to provide where I think there is a key role to be played. So to try to illustrate my point a bit more, I have a modification of something that is called the UHC cube, where I am seeking to illustrate the relationship between these benefits or services, the quality at which they are provided, and the extent to which they are equitably available. So the extent to which, for example, somebody who is pregnant is able to use antenatal services, or the extent to which somebody with the TB diagnosis is able to access TB care. So that's the equity piece. And the blue cube in the middle illustrates the current budget that we have for this imaginary system that I'm speaking about. So in this particular version of the cube, what you have is that perhaps about half of the things that we know work for health. Okay, so obviously that's a big idea, but imagine that about half of the things that we know work are being provided within the system at some level, but they are only reaching about 50% of those in need of the service. So coverage of those in need is about 50%. So there's quite a way to go in order to achieve equity. And the quality is said to be moderate. And that is an illustration of one way that one could be allocating one's budget. But if one wants to move closer to UHC, the argument is that one needs to think about allocating differently. So now imagine you've got exactly the same amount of money, so the budget hasn't changed. You're still in the same gloomy economic context, but under this illustration, you are now limiting your services, sadly, but you're limiting your services so that you can achieve a better coverage of those in need and a better level of quality. And most people would argue that the second UHC cube represents a system that has moved closer to UHC than the previous UHC cube. And the money hasn't changed. And that's quite important because in my experience, the money doesn't change, but we pretend that it's going to. So the money hasn't changed, but what we have done in this system is we have now been prepared to unfortunately limit benefits in order to achieve equity, because we have decided that equity is more important than having a whole bunch of things that are aspirational. Another way of understanding this is a little bit triggering for all of us in South Africa at the moment, which is to draw on an analogy of Eskom, where we know that sometimes we have a supply-demand mismatch in terms of our use of electricity versus the supply of electricity. And we definitely don't want a blackout, because that's a very bad outcome for the country. It could take quite a while to turn the power back on if the grid fails. And so what we're prepared to then do in South Africa is this notion of load shedding, where we shed we shed people from the grid, sadly, in order to avoid blackout. And so this idea of being explicit about one's benefits is a bit like load shedding, unfortunately, because one is choosing the package of services or benefits that can be feasibly delivered within the resources that are likely to be available. So the health benefits package, I've been trying to illustrate it in as a simple way as possible, but it is an extremely technical thing. And so it's a listing of the promotive, preventive, treatment, rehabilitative services to be offered at a particular level of care. Normally it's done through ICD-10 coding, and it includes a full specification of the medicines, diagnostics, vaccines, devices, and models of care that the system is proposing to provide. And we know that the National Department of Health and the NHI office has been working on the package for South Africa for a number of years already, focusing initially on the primary healthcare level and naming this package the Service Benefits Framework. We also know that the WHO has been plugging away at this too, and they have a UHC compendium which provides countries almost with an example of what it looks like to be creating this explicit listing of services. And you can follow the link here and you'll be able to see the kinds of details that it goes into in terms of everything about what the service involves. So it's an extremely technical thing. So I've been talking about it like it's not, just to illustrate what I mean, but it is in fact extremely technical. So given that hopefully I've made a case for actively choosing health services or benefits, the question then becomes of how one should achieve this. How should this priority setting take place? And globally, generally speaking, this priority setting process takes the name of health technology assessment. In a way, a slightly unfortunate name because the word technology is misleading for people. But what it actually is a multidisciplinary process. So not just health economists, definitely, in fact, hardly any health economists. It's a multidisciplinary process that uses explicit methods to determine the value of an intervention or benefit at different points in its life cycle. The purpose is to inform decision-making in order to promote an efficient, equitable, and high-quality health system. So in other words, the purpose of health technology assessment is to help us to choose our benefits so that we can achieve equity, in other words, so that we can achieve universal health coverage. And in yellow, I've highlighted just to emphasize that when in this particular naming convention, a technology is an intervention developed to prevent, diagnose, or treat medical conditions, promote health, provide rehabilitation, or organize healthcare delivery. And it can be a test, a device, a medicine, a vaccine, a procedure, a program, or a system. It can even be an information system, although it's quite difficult to do that evaluation properly. So generally speaking, globally, when people talk about priority setting, they call it health technology assessment. And a number of countries have health technology assessment agencies. Probably the most famous one is the UK system, the NICE, but other countries have it too. And within our proposed national health insurance, you will also find that there are various bits and pieces that talk about having priority setting and talk about having health technology assessment. And my understanding that is that progress has actually been made on this already. And there is a group that's already set up in the NHI fund under the banner of health technology assessment to start taking this forward. So just to clarify a bit, where does HTA fit in the health system? So generally speaking, at the moment, what we have is, say, a new medicine is developed. The first thing that happens is it has to go to SAHPRA for regulatory approval. And then after that, it can be potentially used in the healthcare system. And the question that SAHPRA would answer is, under controlled conditions and compared to placebo, is this thing safe? And actually also, does it do more good than harm? What HTA does is it comes between regulatory approval and use in the healthcare system to answer another set of questions, such as in routine practice and compared with existing health services or benefits, so not compared to placebo any longer, now compared to what we're currently doing, do the gains that we expect to receive from this intervention or service or benefit or technology justify what are normally additional costs? And is that a good enough deal to make it okay that introducing this new thing inevitably means we're going to have to do less of something else? So always bearing in mind the opportunity cost of bringing something in that is new means reducing something else if there is no increase in spending. And normally there is no increase in budget. And also the HTA system ought to consider various other social value judgments, and I will go into some of those in a moment. So the idea is that if one were to do this priority setting well, if one were to really invest in health technology assessment, one would be able to determine these benefits in such a way that one would improve the cost effectiveness of the offering, so improving efficiency, improving the extent to which one moves towards an equitable resource distribution. And also, my favorite part in a way is that one would achieve a greater level of transparency and accountability in decision making. So moving away from decisions that are sometimes made by political heads and moving very much into a system where everybody should be able to understand what decision has been made and why, and it must be an open process. And taking into account a variety of different values. So at the moment in our sort of nascent HTA system in South Africa that sits under the National Essential Medicines List Committee, we have clinical effectiveness that is done very well and has been done for a number of years already. More recently, it has been broadened to include considerations of cost effectiveness, as well as issues to do with the budget impact and whether we have enough budget or are prepared to place enough budget on this in order to achieve equal access for equal need. So those are normally the parts that are quantified. In addition to these quantified parts, generally there are considerations of a bunch of other criteria or values that reasonable people would feel to be important in priority setting. And these are things like how severe is the condition and what will the intervention be able to avert, particularly in terms of a serious outcome. So this generally is there to take into account that people do care about life-death decisions slightly differently than how they feel about interventions that just improve health but don't have a mortality impact. So that's to adjust for the mortality impact. Sometimes one considers who the population is. I'm not a big fan of that, but that does sometimes come into it, to do with economic output. As I said, I'm not a big fan of that because I feel that in a public health system, you should not consider economic output in how you allocate your resources. Everybody should have equally strong grounds for receiving care. But I am a fan of things like whether it affects a previously disadvantaged population, so that's another form of equity, whether it affects a deserving patient group, another form of equity, or whether it's a priority disease area, and that includes things like infectious diseases where treatment can have an impact on prevention. So things like HIV treatment would come in under priority disease areas. But what I'm not a fan of is the ones in orange. So making decisions for political reasons, making decisions because it's requested by clinicians or experts, or making decisions because it's requested by patient groups. So the idea with HTA is that we take away all one's sort of ability to maybe unfairly influence things in order to make it based on evidence. So basically making it an evidence-based medicine process that is transparent. So in conclusion, there's a lot that still needs to be resolved as we move towards the implementation of the National Health Insurance and moving closer towards UHC. The first point is that at the moment we are concerned about the legislation, but UHC cannot be implemented by top-down legislation alone. And this idea of explicit benefits has many merits, but it is a bit of a one-size-fits-all. And it's important to note that provincial, district, sub-district, and facility managers should have a role in ensuring that the benefits can be tailored to the local context to a certain extent, and clarifying how that will work will be key. We need, of course, to move forward. So some progress has been made on HTA. We have an HTA methods guide nowadays, but we need to actually set up the system and invest in it and make it functional and start to show that it is a valuable system. And then we also will need a lot of monitoring and evaluation systems so that we can keep checking whether we're achieving equity. And for this, having a functional electronic health information system is obviously an essential precondition. We also are going to need to think a lot about the role of universities in generating the capacity that's needed, and imagining into a future of electronic data. What kinds of skills are we going to need? And so it's the kinds of skills that we think we're going to need are things like data science, cybersecurity, demographic and disease modeling, epi and biostats, evidence-based medicine, some of the health economic skills, some of the actuarial science skills, definitely management and leadership skills, and definitely governance and systems thinking skills. And so these positions need to be created, and universities need to align their curricula to ensure that we're teaching people in a way that enables them to actually do this, given that none of us actually have done it before, because it will be entirely new for us. But nevertheless, it is our role to think about making sure that our curricula are aligned to how we imagine the health system is going to be in the next 15, 20 years' time as we move further into the fourth industrial revolution. And I think that there is a key role for universities and UCT in this space. So in summary, in my view, choices around benefit packages are going to be and are critical in the movement towards UHC. That is how we move from rhetoric to reality. And I think that this is an important and exciting area for health systems development going forward. So that's it from me, and thanks, Jo.
Thanks, Sue. I mean, it's so exciting to hear what the future of our healthcare system would sound like, but also how universities and how we as academics and students really can play an active role in moving UHC forward. Jen, would you like to start sharing your screen? And while we wait for Jen to get ready, let's see if anyone would like to ask a question before I introduce Jen. It's hard to say no to Prof. Maswime. Here she goes.
Cool. Thank you so much. Another question, just to say huge thank you, Sue, for joining us and for sharing this. We'll keep it as a resource for the team. And thank you to you, and also Jen in advance. Thank you for also sharing your sharing, being part of today. So huge thank you from the Global Surgery team.
Pleasure.
No worries, Jo. I have a slight technical issue in that when I open my share tray, there aren't any options for me. Shall I try and email my presentation over to you?
Yeah, absolutely. Welcome to do that. In the meantime, while we sort out the presentation, is there anyone who has a question for Prof. Cleary? Okay, Jen, you just let me know when you've sent it and I will open it up. All right. Okay. So, Sue, I think I have a question for you if you're ready.
Sure.
So, as advocates for universal health coverage, where do we get involved? Where do we, as academics, students, etc., how do we contribute toward the program of universal health coverage? Just if we use South Africa as an example.
I think that one option is the People's Health Movement. So they're quite involved there. And I like it because it's not a disease-specific movement. So I think that that's good. I think that the other consideration is from a teaching perspective. So that's, I guess, how I sort of see my role. But also I do quite a lot of technical support to policymakers, getting involved in sort of some of the aspects of UHC. And I think I am a fan maybe of the quiet technical support approach over the activism approach, because I have found that to be successful for me. Although one needs activists as well. So perhaps somebody like me likes to play a more sort of technical support role. Others are needed to play the activist role so that they actually.
Great. And maybe I can just ask you about where we are in the process in our country.
Sorry, I think I just got muted.
I also
Was
got
muted
muted.
all along. Okay.
I think a universal decision around speaker coverage was made there. So whereabouts are we in South Africa in terms of implementing universal health coverage?
I mean, I think it's difficult to answer that question. So I think that we've gone somewhere to delineating the service benefits framework for the primary healthcare level. And I think that what be useful from a global surgery perspective is to think about doing the same on that side. And so that when they start asking for it, because there's a hell of a complicated set of analyses that are needed, but so that when people start asking for it, you are ready to say, this is what we think are the essential services that need to be provided. And these maybe are some of the other ones that are more difficult. And then to start thinking about how to do that analytically. And I think surgery is a bit of a more complicated one than many of the other areas, and to start collecting the data. Someone just muted me again.
Hi guys, the mute all button is not fun for everyone. But well, I think it's an exciting time for us, and I think that having these conversations and advocating for engagement in the change is really exciting. And so much of healthcare, I think healthcare workers can so easily feel disempowered by their systems. But the answer is, the reason I'm asking about where we are in our process is there is an opportunity to give inputs on white papers, and we as academics can influence the way that we experience our healthcare systems in the future if we're informed and active about it.
Yeah, and the Faculty of Health Sciences actually did do a big input on the NHI bill. In 2019, we led a process to generate that input, and it was presented to Parliament and so on and so forth. But it was one of hundreds, so I don't know to what extent we made an impact. But I think we probably did. I think we made a good input on it, and I think we should plan to make further good inputs in the future.
Absolutely, and I'm excited to see what we can do in terms of influencing perioperative services as well. Patrick put a lovely comment here saying there's a bias towards the patient lens in advocating for UHC, and more so from the financial aspect. Shouldn't we be addressing both supply and demands? Thanks. That question comes from Uganda.
Absolutely, and I think that for me, being explicit about the benefits is how you get demand and supply to meet. So as economists in other markets, not in the health market, but in other markets, we have a price mechanism which gets demand and supply to meet. In healthcare, we don't have that because we don't want user fees. And so what are the ways that we get to supply and demand to meet? It is through being explicit about the benefits that are feasible. Thanks.
Thanks so much. Jane, how are you doing?
The problem that I just experienced was that the load shedding had stopped, which meant that there was a switch around and I lost my data. And I'm just on Wi-Fi at the moment, but I seem to have trouble sending the file. It's probably because it's 14 megs, but it's in my outbox and seems to refuse to get to you. Is there a way you can make me host? I'm not very familiar with Teams, but I'm just wondering if I could try to troubleshoot why my share tray doesn't give me any options.
So Amy is the host of this meeting. Amy, if you wouldn't mind trying to make Jen host, please. Guys, Jen is coming to us from rural Eastern Cape today. We were there trying to work last week, and we went through a good solid 8-hour patch with no electricity and no phone signal, let alone Wi-Fi. So a difficult place to work.
Okay, so I can see that Amy's playing around, and it says currently only meeting organizers and presenters can share. So if Amy can make me a presenter, I wonder if that would change something. Sorry about this. And in the meantime, Joe, I'll try, and I'm wondering whether it would be more reliable if I switch back to data, although, currently it looks like I have. Wi-Fi. It's just okay. Let me see. Thanks, Amy. I can see that you've no same issue. It's not turning up in my share tray. I don't know why that is.
The Eastern Cape is problematic sometimes when we have to share, that we have found in the past.
That's weird. Do you know what? I'm going to just try one more time to email you, Joe, using my Wi-Fi connection. If that doesn't work, I'm going to just hop back on using my hotspot.
Are you able to maybe just zip the file to reduce the size? Because it might be that it's a size issue if it's too big.
Yeah,
maybe turn it into a PDF.
Yeah, let's try doing that. They're all piling up in my outbox. I don't think I can. I'm going to just switch to the hotspot again because I seem to have got a decent hotspot. Sorry, let me try that.
All right, everyone, while we wait for Jen, so after Jen's presentation, we're going to have another slot for questions. If you have any comments or questions, please continue to pop them in the chat. Jen, I can see, and I'll let you know when you can see the slides.
Sorry, Joe, say that again.
I can see you, and I'll let you know when I can see your slides.
Okay, great. Share tray still isn't working. I'm just going to try sending you my slides again. Sorry, Joe.
No stress. Jen, are you up for presenting without slides, or are the slides very important?
I can present without slides, I guess. That wouldn't be my preferred, but
it's no one's favorite, I know.
Okay. Let me just put my presentation up for me. Okay, everyone. Let's get going. I can't see anyone. Oh yeah, okay, here we are. All right, let's finally get going. I'm sorry about all the technical difficulties. I have to say this would be much better if you could see the visuals, but no matter, the show must go on. So, so this talk that I'm going to be doing is entitled Surgery and UHC, and where do we stand? And I'm going to be arguing that surgery should certainly be part of the benefits package that that we heard about from Sue, and the justification for that. And also going to be then delving into how to best deliver that surgical package. So talking about strengthening surgical services at the district hospital level, but also the top-down approach of talking from a national surgical planning side. And then we're going to be covering the barriers to implementation. So I think many of you, this is a diverse audience, but many of you will already be familiar with the Lancet Commission on Global Surgery and its 5 key messages. And that was really saying that surgery is a huge problem and it's not being adequately addressed on the global health agenda. So 5 billion people lack access to safe and affordable surgery. We need to be providing 143 million more procedures per year to avoid death and disability. 81 million people face catastrophic expenditure as a result of surgery. That includes the direct and indirect costs. And then it would take a huge investment of $350 billion. But if we spent that, then there would be a saving of $12 trillion over the years from 2015 to 2030, when this was originally modelled. And the last part is to say that surgery is an indivisible part of healthcare. So Sue has nicely defined UHC for us, and just to recap, it means that all people have access to the full range of quality health services that they need, when and where they need them, and without experiencing financial hardship. So that's defined as Sustainable Development Goal 3.8. And in the same year, 2015, as when the SDGs were published, and at the same year that the Lancet Commission came out, there was a nice confluence of those things at the World Health Assembly to say that surgery is an integral part of UHC. And that really was culminating in this resolution 68.15 to say that strengthening emergency and essential surgical care was a critical part for universal health coverage. But the traditional perceptions of surgery are that it's particularly resource heavy. It requires skilled people. It requires lots of equipment that needs to be maintained, lots of consumables. You need a clean theatre. And the risks that come with surgery can potentially be high, death. So the other issues that we've experienced are that specialists have enjoyed their status as experts in tertiary centres, and they sometimes have been resistant to sharing their expertise, or for that expertise to be deconcentrated to other areas that aren't tertiary centres. But the problem is that tertiary centres don't have the capacity to do 143 million more procedures per year. And patients can't easily get to tertiary centres. And we see, and I'm speaking from Madwaleni right now, a very, very rural district hospital. We see what the reality actually is on the ground. So there is this this model of the 3 delays of getting care. So the first delay is in seeking care, the second delay is in reaching care, and the third delay is in receiving care. And I'm seeing that, in the hospital that I'm at. So I see firstly the delayed presentations. Even if a referral is appropriate to send from here to the local tertiary centre, refuse the referral is common because there simply is an overburden system. Even if the referral is accepted, there are further transport delays. Even if the patient arrives at the tertiary centre, there are delays to getting to theatre. And even if a patient gets surgery at the tertiary centre, it doesn't necessarily equate to high quality care. So how do we reconcile that then and surgery with UHC principles? Well, there was a document, again in 2015, produced by the World Bank and WHO, called Essential Surgery, and it's the Disease Control Priorities 3rd edition. It says that there are 44 essential surgical procedures that, if they were provided, would avert 67% of all avertable deaths in LMICs. It is extremely cost effective. Full financial coverage of these would yield a benefit to cost ratio better than 10:1. And, if we think again about the definition of UHC, it's about providing quality services when and where patients need them. And given that tertiary hospitals are often too far away, what we're talking about then is that these essential procedures really need to be performed at the district level. So, the 44 procedures that are recommended to happen at the district hospital. And 28 of those 44, so 28 of those 44 should happen at the district hospital, and 23 out of 28 of them are emergency procedures. And they cover things that are your core obs and gynae procedures, so safe cesarean section, perhaps a hysterectomy for uterine rupture or postpartum hemorrhage, tubal ligation. Then there are general surgical procedures such as a gallbladder removal, repair of perforated intestine, appendicectomy, things like hydrocelectomy, and then there is injury. So resuscitation with ATLS principles, a chest drain, a trauma laparotomy, and it goes on. So it's interesting being at Madwaleni because I can see that I am in a very special place where the clinical team feel empowered to improve their surgical services, but they're still actually quite quite far from what the recommended level is. And there do need to be more efforts in strengthening district level care. So I think the movement has started in South Africa. Convening people to talk about strengthening grassroots advocacy for rural surgical care. And she held the AfroSurg 3 conference in September, which was specifically looking at that. And I have to say that being at Madueleni, it's made me aware of the kind of facilitators for strengthening district level care. So apart from there being obvious need, there is positive change. All clinical team members have a voice. And really importantly, there's a family medicine program. So part of the curriculum for that family medicine program is surgical procedures. So that is an automatic drive to improving the surgical service. But from the other side, we have to think from the top down. And there does need to be coordination of efforts that align with a national health strategic plan in order that we are providing equitable and quality surgical services. And that's where national surgical, obstetric and anaesthetic plans come in, which essentially set out a roadmap for countries I was really interested to hear that Sue said, often they're a kind of wish list and they're very aspirational, and yes, they often are. And I'll come to kind of some that have been formulated around Africa, but essentially it is at least some political commitment and hopefully a feasible strategy to strengthen surgical services in the country. And there has been a varied uptake of NSOAPs to be used as a tool across Africa. Zambia seems to be leading the way. It was the first to create a national surgical plan and is in the process of renewal. And there have been many other countries that have stalled in formulating their plans. And so I think one of the issues has been that data is not forthcoming. And I would like to point to Ethiopia as a good exemplar of what we can do with data. So Professor Graham Fegan was the person who highlighted that in South Africa, the only surgical indicator that is reported at a provincial and national level is the number of cataracts that are done. And it seems that there are far more relevant indicators that should be collected. And Ethiopia, as part of its national surgical plan, made sure that the information management system was such that there are plenty of other indicators that are being reported up the chain. So they include surgical volume, perioperative mortality, the rate of safe surgery checklist utilization, surgical site infection rates, anaesthetic adverse outcomes, delays, elective surgical admissions, and the list goes on. There are actually 7 level. And I think that is the direction that we in South Africa need to go in. So I'm going to stop talking about NSOAPs, but offer some other thoughts on why I think surgery is kind of uniquely challenging. If we just take the converse and think about medical conditions, diseases are very amenable to mapping out in a kind of care delivery value chain. And that, I wish I could show you the slide to show you what I mean, but essentially it maps out kind of from monitoring and preventing to diagnosing, preparing the patient, intervening with the patient, recovering and rehabbing, and then monitoring and managing. Nice pathway that the patient goes through and have data collected along the way. And the intervention is medication for medical diseases. And the whole system of that makes it very attractive to funders because there can be vertical programs instituted. And when money floods into these vertical programs, there is a byproduct generally of the whole healthcare system being strengthened. So, for example, if there is an HIV project that Partners in Health want to fund, maybe that will come with training a whole group of community healthcare workers. And ultimately, those community healthcare workers will add value to the whole healthcare system. And so there is this effect of primary healthcare strengthening through investing in vertical programs. But surgery isn't like that. Surgery is the intervention, so just one part of this care delivery value chain. And it cuts across a whole host of problems. But you already need a system to deliver surgery. And that system has multiple points of failure. So added to that, it's incredibly messy to evaluate. It's tricky to justify whether a surgery it's tricky to kind of know whether a surgery is justified, to judge the quality of anaesthetic. There are various different complexities of surgery, and then, picking up, especially in the context of resource limitation. So for that reason, I think it has been much less attractive to donors because they just don't know what they're getting. The other thing to say is that surgeons can be very territorial. And I think it's true to say that they have been quite resistant to talking explicitly about task shifting and task sharing. So giving up their responsibilities or sharing their, the traditional remit of the surgeon and letting maybe non-physician clinicians take up those roles. And we have said that for UHC to happen and surgery to be part of that, then surgical strengthening needs to happen at district levels. But the voices around the policy table really don't include those stakeholders. They don't include the generalists who are going to be doing surgery in these district hospitals. It tends to be surgeons from tertiary centres. But I want to end on a hopeful note, I've said that it's been difficult for surgery to be funded. However, there is money available, and recently the Japanese government gave Zimbabwe $600,000 to support surgical system strengthening. And the US has also changed its legislation around what USAID can fund, and that also includes surgical strengthening measures. And to say that surgery is still on the policy agenda. So the WHA that's coming up in May has a draft resolution around emergency, critical and operative care. And, there has been debate about whether if surgical care links up with emergency care, does that dilute surgery? But really, I think we need to be leveraging other things on the political agenda to try and keep surgery in the limelight. And I think pragmatically that is a good step forward. And the other thing to say is that it's particularly important right now because in the WHO there are very few champions within the higher structures of WHO that are surgeons and that can advocate for surgery. I just want to end on a kind of note of caution, which is that, I've been talking a lot about surgery, which I'm aware is used to a kind of one of the healthcare services, but the healthcare services are in a so much broader context of a healthcare system. And I'm really glad that kind of Sue set the context for talking about that system in terms of governance and organisation, financing, and levers to make any meaningful healthcare reform. And surgical services are part of a very complex system. You can't address surgical services without also reforming those things: governance and organisation, financing, and resource management. So in summary, I just want to highlight the fact that surgery isn't just for tertiary centres. District hospitals can deliver quality surgical services, and that, if we invested in that, that would strengthen the overall healthcare system. We need a top-down approach, and that's to coordinate and adequately resource surgical care. And then there is this broader context for healthcare system strengthening, which NSOAPs in themselves don't address. Okay, I'm done. I'm going to stop talking there. Any questions?
So much, Jen, for your time. and a nod to Eskom, who managed to make mention in the first presentation on purpose and the second presentation by mistake. Load shedding is pervasive. All right, everyone, so we've got 2 minutes left and time for one question. If there's anyone who has a question or a comment, Sue, you're also welcome to comment on surgery in UHC. So time for one comment or question. Anyone put your hand up and unmute yourself. We'd love to hear from you. While we wait, Jen, just to confirm that at exactly 13:27, I received your PowerPoint ×3 in my inbox. Sorry. All right.
I'll make a comment.
Are we
I
ready?
knew that was going to happen.
Thanks, Jen. It was so interesting, and I'm so sorry I couldn't see the slides. I'm sure that they would have been fantastic. And I was reading through the Global Surgery Cost Effectiveness Systematic Review, sort of, you know, I can't help multitasking. And colleagues, there's only there's 20 studies globally, right? So students, this is definitely something where there's a huge evidence gap. And very cost-effective interventions as well. So it's a very interesting paper. And the other comment is that with the NHI focusing initially on the primary healthcare level up to and including district hospitals, how can surgery be included on the benefits package in the shorter term, and how can you advocate for priority setting to be used to make these choices? Because given the results on cost effectiveness, the gap is not having an explicit mechanism for making choices, because given how cost effective things are, things ought to be included. So that's just from my side. Thanks.
Thanks, Sue. I think that's a really hopeful and wonderful note to end on as we hit exactly 13:30. Guys, there's a role for us in advocating for how our healthcare system transforms, and we as a community definitely need to engage with it more. I'm going to say a big thank you to our speakers for their time. Thanks, Jen, for being brave despite your challenges, and thanks, Sue, for your wonderful presentation as well. 2 amazing speakers, and we look forward to seeing you next month. Thanks, everyone, for your time. We'll see you next month. Thank you.
Bye. Thank you.